The following podcast is part of a certified educational activity titled Paving the Path for Optimal Prostate Cancer Care, preparing advanced practice providers to integrate modern therapies into tailored treatment plans. Access the entire activity and complete the post-test at peerview.com/DBK860. Downloadable slides and practice aids are also available.
Hello, I'm Brooke Looney, an oncology pharmacist with the specialty pharmacy at Vanderbilt University Medical Center in Nashville, Tennessee. Welcome to this educational activity entitled Paving the Path for Optimal Prostate Cancer Care, preparing advanced practice providers to integrate modern therapies into tailored treatment plans. I'm pleased to be joined by my colleague, Dr. Alicia Morgans, a genitourinary medical oncologist from the Dana-Farber Cancer Institute in Boston.
Thank you so much for having me today. I'm excited to talk about how different members of our care teams can support therapeutic advances for patients with advanced prostate cancer and share our experiences for effective integration and management.
Today, we'll focus on three key goals for optimizing prostate cancer care. First, we'll look at the clinical evidence supporting systemic treatment intensification, so going beyond the traditional androgen deprivation therapy to incorporate additional agents that help to improve survival. Then we'll discuss the importance of collaboration across the patient care team. And finally, we will focus on proactive management of adverse events and patient education. Let's start by looking at the current status of prostate cancer in the United States. Prostate cancer remains one of the most common cancers in men. In 2025, it's estimated to account for 15.4% of all new cancer cases and 5.8% of cancer-related deaths. That translates to over 313,000 new cases and over 35,000 deaths. Advanced practice providers are gatekeepers in the prostate cancer care setting, offering holistic support through care coordination, psychosocial assessments, and communication across disciplines. They understand the mechanism of action for multiple agents, can support patients on diverse therapies, and provide vigilance and education on adverse events. This team can include pharmacists, physician associates, nurse practitioners, and clinical nurse specialists, all working alongside physicians to improve access and outcomes. Effective communication among teams is essential because prostate care involves numerous therapies. That can be chemotherapy, androgen deprivation therapy, androgen receptor pathway inhibitors, PARP inhibitors, radioligand therapies, and combination of therapies. This makes communication critical because teams must provide clear education on the expected adverse events, also encourage patients to report issues early, and in training nurses and pharmacists to triage patient-related symptoms. Maintaining connections between the different clinical departments, so the ED, primary care, urology, and oncology, ensures that there's seamless care across the board. Ultimately, optimal care relies on collaboration among the multidisciplinary and multi-professional teams. So here are two patient scenarios that we're going to consider. Ben is 65, a retired sales rep who enjoys golf. He had a radical prostatectomy 5 years ago and now has a rising PSA. Eli is 78, enjoys chess and time with his grandchildren. He has a rising PSA, reports fatigue and bone pain, and has a history of mild coronary artery disease. So some items to think about with these two cases. What key discussions should we have with these patients and their families? And how did comorbidities influence treatment choices? And we'll come back to these cases later. Let's begin with a review of patients who have localized prostate cancer but experience a biochemical response. Dr. Morgans, can you walk us through the data?
Of course. So let's dive in. When patients have had primary treatment with a radical prostatectomy or radiation, they can develop biochemical recurrence or biochemical relapse, which lets us know, of course, that the cancer has not been cured despite curative intent treatment. This can happen anywhere from 10 to 40% of the time, with the higher rates, of course, being associated with patients who have high-risk localized prostate cancer or locally advanced disease. Also importantly, though, we know that there are different risk stratification or risk strata that patients will fall into when they develop this recurrence, with some patients potentially living with a detectable PSA for many years without any real risk of developing metastatic disease, and they will ultimately die from something other than prostate cancer. Where other patients have higher risk biochemical recurrence, will develop metastatic disease, and will succumb to prostate cancer as the ultimate cause of their mortality. So we can think about different parameters that help us understand this risk stratification, because it is those patients who are at highest risk of dying from prostate cancer and developing metastatic disease that we want to treat in this biochemical recurrence setting. Some of the things that we think about are the time since initial definitive localized therapy to developing biochemical recurrence. And if this is less than 2 years, that would be a higher risk population. The prostate cancer or PSA doubling time, PSA-DT, as you can see here. When the PSA doubling time is short, we know that those patients also have a higher risk of developing metastatic disease and dying from prostate cancer. And having a high Gleason score of a grade group 4 or greater, this is a group that may be at highest risk. And although our indications in terms of our treatment approvals do span the entire biochemical recurrence state, we often try to focus that intensified treatment in patients who we know have the highest risk of suffering from prostate cancer. The EMBARK trial was the first study in many years to actually assess biochemical recurrence and to try to provide a treatment for this biochemical recurrent population. And it's the first study that actually specifically has an indication for a drug in the biochemical recurrence space. This is an incredibly difficult area to investigate because these patients have a long life expectancy and because it is potentially years before they develop complications. And so it really is a credit to the investigators and to the group that developed this study that we do have access to this information and that we now have an approval for enzalutamide in high-risk biochemical recurrence. Again, actually the approval is across biochemical recurrence, but we mostly try to target those patients who have high-risk BCR. Well, who was included in this study? This is a group of patients who had had prior prostatectomy, prior radiation therapy, and they had no evidence of metastatic disease on conventional bone scans, CTs, or MRIs. This is really critically important because at the time when this study was developed and at the time of the development of the definition of biochemical recurrence, we did not have things like PSMA PET scan. And so we use these conventional imaging strategies to say that people did not have radiographic evidence of disease. It's highly likely that these patients would have had something on a PSMA PET that we could identify had we had that technology available to us. In any event, these patients had negative conventional imaging and they had a PSA doubling time of less than or equal to 9 months. As I said, they had prior primary treatment and they were randomized 1:1:1 to receive leuprolide as a GnRH agonist control arm, or leuprolide plus enzalutamide, or enzalutamide as a single agent. And all of these patients were followed until they got to a PSA that was undetectable, at which point they could take a holiday from systemic therapy in the way that we normally do intermittent therapy in biochemical recurrence. If they did not achieve that PSA of less than 0.2, then they would stay on continuous therapy. And the primary endpoint in the trial was metastasis-free survival by central review on conventional imaging, CTs, bone scans, MRIs. And so this study, again, was really meant to try to mimic the way that we use intermittent therapy in biochemical recurrence and to understand how to best try to prevent complications like metastasis in this population. And so here we can see the results of this particular outcome. The primary endpoint on the left, metastasis-free survival, looking at the enzalutamide plus leuprolide combination versus leuprolide single agent. And we can see that when we included enzalutamide, this was associated with improved metastasis-free survival as compared to leuprolide alone, hazard ratio 0.42. And on the right-hand side, secondary endpoint, enzalutamide monotherapy, also superior to leuprolide in terms of prolonging metastasis-free survival. And so this led to the approval of enzalutamide with or without leuprolide in this clinical scenario. Here we can see the overall survival, importantly, improved with the combination of enzalutamide and leuprolide versus leuprolide alone. I want to point out that this is a population that is many years from reaching a mortality endpoint in most cases, and actually a population that will receive many additional therapies. So the fact that we could intensify here by adding enzalutamide and still prolong survival is really surprising and critically important. We see that hazard ratio 0.597. It is extremely strong, suggesting that the earlier intensification makes a meaningful difference for our patients in this biochemical recurrent setting. We also have the overall survival information for enzalutamide monotherapy, which suggests that it's actually similar survival to leuprolide alone. So no clear improvement over that, but at least similar. And with a different side effect profile, this can be important for some patients to have that option to use a non-castrating treatment with enzalutamide monotherapy as a way to prolong the time to metastasis and to maintain that survival as compared to leuprolide alone. I think also as we consider risk stratification, PSA doubling time, as I mentioned, is really, really important. So knowing whether we have calculated PSA doubling time is really important. There was a study published about a year ago that looked into whether treating providers actually knew what the PSA doubling time was for their patients with biochemical recurrence, and 2/3 did not know. It's, I think, really critical for us to recognize this shortcoming perhaps in our practice so that we can start to calculate this, because without the PSA doubling time, we're not performing that risk stratification, and we're not necessarily thinking about intensifying with enzalutamide in this setting where we know we can actually get a survival advantage if we do intensify on those patients who are at highest risk. So as we think about this, and with any treatment intensification or treatment decision for that matter, there are definitely safety and management considerations that are going to be important to keep in mind. So let's take a look at some of them.
Thank you, Dr. Morgans. So when we're looking at safety across different regimens, this slide compares side effects across enzalutamide combination, leuprolide with placebo, and enzalutamide alone. Hot flashes and tiredness or fatigue are frequent overall, with up to 69% of patients experiencing hot flashes and 47% experiencing fatigue or tiredness. Gynecomastia is more common with enzalutamide alone, so that 45% versus the combination therapy of 8%. And other notable side effects across regimens include joint pain, high blood pressure, falls, and breast tenderness. Managing adverse events with ADT or ARPI therapies requires proactive strategies. So we know that a lot of patients, or most patients, are going to experience some degree of fatigue, hot flashes, night sweats, and we can help to manage those by counseling patients in advance. Fatigue, muscle loss, and weight gain can be addressed with counseling on diet, exercise, use of resistance training. Also, bone loss, calcium plus vitamin D, use of bone protective agents, and exercise can be helpful. And to address hot flashes and night sweats, lifestyle changes such as dressing in layers that can easily be removed, sleeping with a fan can help. Also, cognitive behavioral therapy and a variety of medications as well. The key takeaway is that proactive management is essential. So let's revisit our patient case. Ben was our 65-year-old retired sales rep who enjoys golf. He had a radical prostatectomy 5 years ago with Gleason 4+4. He had negative margins and no nodal involvement on scans, and no adjuvant radiotherapy was given. Now his PSA is rising with a PSA doubling time of 6 months. So Dr. Morgans, how would you approach this patient's care?
Well, I think in this particular case, as we see that rising PSA, the PSA doubling time is really short. And just to note, he didn't receive adjuvant radiotherapy because of irritable bowel syndrome. He's not able to get radiation therapy. Then systemic therapy is absolutely the way to go. And this is a setting where we would ensure that the CT and bone scan is negative, and we would think about and talk about things like leuprolide with enzalutamide or enzalutamide as a single agent, just like the EMBARK study that we just talked about. In shared decision-making conversations with Ben, I think it was very clear that in addition to wanting to continue to play golf and maintain his quality of life, overall survival was of high importance. And in that setting, the combination of enzalutamide and leuprolide would be the combination of choice. And it also matters in the way that the side effects may affect a patient. Enzalutamide monotherapy having different side effects, including maybe fewer hot flashes, but more gynecomastia, and enzalutamide and leuprolide having more hot flashes, less gynecomastia, and maybe improved overall survival. So that's the kind of conversation that we had. I wonder, as a pharmacist, and you work in a specialty pharmacy where you have conversations with patients about the start of new medicines like enzalutamide, what kind of conversations would you have about AE management, and how would you encourage Ben to engage with either you or with the team to ensure good adherence to their treatment?
Yeah, so for Ben, we would want to provide counseling up front just to let him know and reiterate discussions that you've had with him in practice about expected side effects, to explain that, different patients have varying degrees of these side effects, but we can definitely proactively manage those. Let the patient know to report side effects, so don't really let them suffer in silence with unbearable hot flashes. If that's what they're experiencing, go ahead and reach out to either your pharmacist or your nurse practitioner. Those are often providers that are easier to get in touch with. I know some patients feel like they don't want to disturb their medical doctor because they're busy seeing other patients. And so just making sure that patients know that that opportunity is there to reach out. We can talk about the side effects they're experiencing and ways to address those, either with cognitive behavioral therapy or the addition of supportive care medications.
When I think about this too, I always tell patients, you can expect some level of fatigue or some level of some effect, depending on the medicine that we start. Do you talk to patients also about the time of day when they take the medications, whether they might consider a dose modification? I think this can be especially important with enzalutamide because some patients do have some fatigue with this treatment.
Yes, that's an excellent point. So we do counsel patients on best times of day to take their medications, and that can be due to side effects or compliance concerns. So some patients do better by taking all their medications in the morning, and that's when they can remember to take them. Some patients, if they're used to taking their medications in the evening or have other medications that they're taking, that they lay out with their toothbrush, then that might be a good time to take their medications as well. Also, if they are experiencing fatigue, that then taking later in the day before going to bed can be helpful for some regimens. Also, when looking at the different regimens, we would want to make sure, what medications need to be taken with food or without food, and take that into consideration as well. But just really help tailor the counseling points to the individual patient, because every patient has different things going on. And I think that's really where it's important to focus in on that individual care.
I couldn't agree more. And so I think it's great time for us to talk about metastatic hormone-sensitive disease.
Yes, we'll move on to metastatic hormone-sensitive prostate cancer, or MHSPC, high volume de novo metastatic disease. So for example, with liver and multiple bone lesion involvement, has the poorest outcomes, while low volume and oligometastatic disease fare better. The survival curve on the right shows that de novo high volume disease patients decline fastest, while low volume metastatic cases maintain better survival over time. And this really underscores the importance of early identification and then tailoring the treatment strategies towards the patient. Clinical factors should guide this approach. So we would want to consider fitness, performance status when thinking about chemotherapy. When thinking about starting patients on AR inhibitors, taking into account other comorbidities and their frailty. Also, metabolic and cardiac concerns are important in evaluating eligibility for abiraterone, and then also taking into account prior treatment. So that they've been treated with another AR inhibitor and have poor toleration. Did they progress on a prior treatment? And these should be, and therapy really should be individualized based on these factors.
Agreed. I think as I consider how do we best meet that prognosis for each patient, we have had a lot of development over the last number of years that helps us do just that and really tailor the treatment approach to the aggressiveness of the cancer. As we can see, there are many combinations that have been developed and have been approved in the last few years. And I think the overarching message that we can see here, as well as considering our practice, is that ADT alone is no longer the acceptable treatment. It is no longer the thing that is our go-to for people with prostate cancer. It's ADT plus something. What we know from real-world data is that we are underutilizing ADT combination therapy, whether it's ADT and ARPI or ADT docetaxel or ADT docetaxel and ARPI. We can always do better. And even in 2023, 35% of patients were receiving ADT alone. It should be, from my perspective, in most of our patient populations at max, somewhere around 10 to 15% of patients who might be best suited with ADT alone. Most of our patients should at least get ADT and an AR pathway inhibitor. And studies like this, the real world assessment, can help us make sure that we at least hold a mirror to ourselves and know what we're doing so that we can attempt to do better. We have seen in study after study, whether it's charted, whether it's Titan, whether it's Latitude, or whether it's Arches, that ADT plus docetaxel, abiraterone, apalutamide, or enzalutamide will be associated with an overall survival benefit as compared to ADT alone. And actually, in all of these trials, there's been at least a maintenance or even improvement in quality of life with the intensification of treatment as well. The long-term Arches data that was relatively recently reported out suggested that there are many patients, maybe even a third, who at 5 to 8 years are still on treatment with ADT and enzalutamide. And this is striking to me, as we used to see a median time to progression on ADT alone of somewhere around 12 to 18 months. So thinking about 5 years, having a third of patients still on combination therapy is really, really reassuring and helpful to patients. What we also know is that those patients who get to an ultra low PSA of less than 0.2 seem to have the longest ability to stay on treatment. These patients have the best response to therapy, longest time to any progression. And we also know that adding enzalutamide or another ARPI to the ADT backbone gives us a greater chance of achieving that ultra low PSA and should be part of our plan. If we don't achieve the PSA that is less than 0.2, we know that patients are much more likely to have progression of disease and develop castration resistance. MCRPC is the phase of prostate cancer that is universally fatal, and it is really imperative that we try to prevent that where possible. And study after study have shown that those patients with an inadequate PSA response are those most likely to develop that. Importantly, clinical trials are trying to consider whether those patients who don't get to a PSA of less than 0.2 should be enrolled in intensification studies, even on top of the ADT ARPI backbones. And so we are further investigating that. But if you get to a PSA of 4 or 7 or even 2, no matter whether the PSA started at 12 or 200, that is considered an inadequate PSA response, and those patients are at higher risk of having progression. We also, of course, know that there are triplets available, ADT docetaxel plus an ARPI, which can be important for those patients who are chemo fit. This was initially described in the Piece 1 data, where we found that patients who had ADT, docetaxel, and abiraterone had superior overall survival as compared to those patients who had ADT and docetaxel as a backbone. This is most pronounced in patients who have high volume disease in that Piece 1 trial. You can see that on the left. Low volume disease, at least in piece one, has not reached maturity to show that differentiation, but this is very similar to the charted data that found that ADT and docetaxel was most beneficial for those patients with high volume metastatic disease versus those patients within charted who had low volume disease. The ARISENS trial included a chemofit population that all received ADT docetaxel and half also received darolutamide, and showed that the addition of darolutamide to ADT docetaxel as a backbone was associated with a reduction of risk of progression and death of about 32% here, with a hazard ratio of 0.68. So really a phenomenal improvement in overall survival, which is consistent with what we saw in piece one for the addition of abiraterone. So telling a consistent story.
There are certain things that we want to take into consideration as far as monitoring and safety. So we want to make sure that we're monitoring for hypertension, as that can be a common side effect, edema, liver function changes, hypokalemia, along with fatigue. And pill burden should be taken into account as well. We want to watch for exacerbation of ADT-related adverse events, assess cardiovascular, cognitive, and bone health. Chemotherapy adds risk for neutropenia, neuropathy, and fatigue, plus taking into account infusion and administration time when considering patients' choices. When choosing an ARPI, dosing and administration differ between agents. For example, apalutamide is once daily dosing. A single tablet of 240 milligrams can be taken with or without food. And we want to make sure to monitor patients for rash, thyroid function, and fall risk. Darolutamide is dosed at twice daily, must be taken with food, and would be the preferred choice for patients with a prior history or risk for seizures. Again, we'd want to monitor blood pressure across the board with these agents. And then enzalutamide has the convenience of the once daily dosing. We do want to make sure to avoid in patients that have a history of seizures, and then monitoring again for falls and blood pressure increases. But across the board and common to all of the ARPIs is fatigue, hypertension, as we mentioned, and hot flashes. Telephone triage can be a very important thing to implement into practice and make sure that our pharmacists and APPs are trained on. So telephone triage can really help determine which patients can be managed at home versus those that need to come in to be seen in person. Early symptom identification minimizes the adverse event severity. So if we can catch those adverse events earlier on and get those treated before they escalate, we can keep patients on therapy longer because they're feeling better. Also, some tools that can be used for early symptom identification that we've used in our practice include electronic patient surveys that we send out within the first 7 to 14 days after starting therapy. And also scheduled outreach calls to patients. Telehealth can provide value for those patients that have travel concerns, and also is able to include other family members that might not be able to make the trip for the in-person patient, and can provide educational opportunities. It's important to consider patient reliability, their comprehension level, also any language barriers, transportation issues, and support resources when we're assessing the best methods for patient follow-up. So some patients are better to be contacted via phone or speaking with a secure family member to provide that historical context, versus some patients really appreciate the ability to use electronic monitoring, and that can, ease their ability and openness to provide feedback as well. So we're going to look at another patient case here, back to Eli, who is 78 years old. And this patient, as we recall, enjoys playing chess, visiting with his grandchildren, and has some comorbidities that we'll need to take into account. Dr. Morgans, how would you approach this patient as far as his treatment plan?
Yeah, so I think we recognize that he has high blood pressure, well controlled, but otherwise is a healthy person. You know, he had a PSA that was elevated at 57. This was measured because he was having some back pain, and primary care checked that out. They got imaging with CT scans that demonstrated metastatic disease in the bone in various areas. And he subsequently had a prostate biopsy with a urologist that showed high-risk disease, Gleason 4+5, prostate adenocarcinoma. To complete his staging, he had a bone scan that showed, again, multiple areas of bone involvement. And when we consider this, plus his pain, his high blood pressure, and other comorbidities as well, it's important to think about, how do we best treat this patient? Also recognizing that he's 78 and his priorities are really around improving his survival, but also around making sure that he can spend time with his grandchildren and maintaining his current quality of life. So in that conversation, we just can discuss ADT and an ARPI with or without chemotherapy. For this particular patient, ADT and an ARPI was the combination of choice. And I think part of that, of course, is insurance of maintaining quality of life. Docetaxel does have an impact on someone's short-term quality of life, but also the fact that he's spending a lot of time with grandchildren. You may be immunocompromised in the setting of chemotherapy, and especially for young grandchildren, this can be an issue if they intermittently get colds, as all young children do, and this was something that he wanted to avoid. When you're talking to patients, it's probably after they've already kind of made these decisions around what their treatments might be. What tips do you have to try to help them stay on therapy and try to help them stay well, whether they're on chemotherapy, which we can get a lot of people through and they can do quite well too, or whether they're on ADT and an ARPI? What are your recommendations there?
Yeah, and I think it's important to emphasize that all these side effects are manageable, and we have different tools to help prevent or mitigate those side effects. So I think it's important to ensure patients up front that we have a team of practitioners that are going to be looking at the whole picture, so that they have someone that is working behind the scenes too, that can help monitor and manage those side effects. Our care team can also help patients with adherence, and if patients are having trouble remembering to take their medications, can come up with electronic means to do that. Encourage patients to mark off on a calendar when they're taking their medications. And then at the pharmacy level, we proactively reach out to our patients to schedule refills. And at that time, we're also asking the patients a series of questions as far as if they're having side effects, what are their concerns and questions, and the opportunity to speak with a pharmacist. In addition, we're providing those patients our direct contact information, and there's ways to reach out via phone and through the My Health portals within the electronic medical records, which has really been a great tool for patients to be able to reach out to their providers and for us to give a quick response. And that response could be just electronically if we felt like we didn't need to escalate it. But if we feel like the patient, might need to come in or needs to talk to another member of the care team, then we can approach that as well.
I think that's so important, and pulling in the rest of the care team also really important. Those physician associates and nurse practitioners help to bridge the gap when I'm not available, and also own those patients and own those side effects and own those burdens just the way that we do and are such important integral members of my team. They work on things like blood pressure, any nausea, constipation, and they also, of course, work with our nurses to make sure that these kinds of side effects are mitigated as well. So it is truly a team effort between the pharmacist, the NPPA team members, the physicians, the nurses, all of us working together to make sure that those patients feel supported and also can stay adherent to the regimen or switch the regimen if that's the best thing for them. So let's also continue to switch gears. Let's talk a little bit about MCRPC, which is our next setting.
Yes. So as we move into discussing MCRPC, we do have a lot of treatment approaches available. We're not going to cover all of the available therapeutic strategies today, but it's important to remember that there are numerous options available. And as we mentioned, care teams can work together to help support patients on a variety of regimens, whether that includes radiopharmaceuticals, chemotherapy, immunotherapy, or the use of PARP inhibitors.
Yeah, so many options available now. And when I think about this, I'm always thinking about what the patient was exposed to before so that I can try to help make that decision for what might be best now. For patients who have only been on ADT before, things like enzalutamide and radium combination per the P3 regimen that we'll talk about in a minute, or for those patients with BRCA or HRR mutations, maybe a PARP and ARPI combination might be best. If they have had prior intensification, as most hopefully will have, patients may be eligible for chemotherapy, either docetaxel or cabazitaxel, maybe lutetium-177 PSMA-617, our radioligand therapy or radium, otherwise single agent PARP. So lots of things in clinical trials, also always important here. P3 was a study that was reported out maybe a year and a half ago or so. Very exciting data because radium-223 has been a medication that we've had available for patients with bone-only metastatic disease for many years now. And this study looked at those patients who had received ADT alone or ADT with a hormone-sensitive schedule of docetaxel in that hormone-sensitive metastatic setting, and randomized them to receive enzalutamide, a highly active control in the standard of care, versus enzalutamide plus radium. And they found that the addition of radium to enzalutamide prolonged radiographic progression-free survival as well as overall survival in this P3 setting, which, again, a little bit surprising that it would have this degree of benefit, but really wonderful to see. I think also very importantly, though, we did see in multiple studies, including the P3 study as well as the ERA-223, that we do have to continue to remember that bone health agents are required to prevent things like skeletal related events when we are using things like radium, which is a bone tropic medication, and then integrating in an AR pathway inhibitor. What we can see in this figure is that when we gave medications like enzalutamide with or without radium, without a bone protective agent, BPA, the level of skeletal related event was unacceptably high. But when that bone protective agent was applied, the rate of skeletal related events decreased substantially and was actually really quite manageable, very, very low rates. And so we can use these combinations of radium with enzalutamide as an example, but we do need to remember bone health and use bone protective agents in this setting. Additionally, in MCRPC, we're increasingly able to use lutetium-177 PSMA-617, which is approved before or after chemotherapy at this point. We know that in the post-chemotherapy setting after progression on an ARPI and docetaxel chemotherapy, it is associated with improved survival. And in the pre-chemotherapy setting after ARPI, it is associated with improved radiographic progression-free survival, and seems to be very similar as compared head-to-head with, using a chemotherapy type of an approach. So I think these are options for us to use pre or post chemotherapy, lutetium-177 PSMA-617, and highly sought after by patients, so something for us to keep in mind. PARP inhibitors also of high importance. These are targeted agents that are going to be approved for patients with HRR mutations, if we're talking about single agent olaparib as an example, or with BRCA mutations post ARPI progression and taxane, if we're talking about rucaparib. Combinations like olaparib and abiraterone and niraparib and abiraterone are approved in the first-line MCRPC setting for patients with BRCA mutations, and talazoparib and enzalutamide approved for patients with HRR mutations in the first-line MCRPC setting. So the indications matter, the genes that they are approved for matter, but we know that these combinations, when compared to the single-agent ARPI, are actually highly, highly effective and very valuable to patients in terms of disease control. So if we want to use them, that means we have to do the genetic testing to identify the mutations that may be targeted. Unfortunately, over 60% of patients are still not being tested for genetic alterations in the US and Europe. And we do also know that these mutations are associated with a worse prognosis. So it's really important for us to identify them and to do what we can to try to shift that trajectory. Both germline and somatic mutations are important, and about half of BRCA2 mutations, as an example, are found in germline and about half in somatic testing. So really critical that we get it all done. And the guidelines from ASCO and from other organizations have tried to keep up with this. They do suggest that for patients with metastatic prostate cancer, we should be doing both germline and somatic testing. Again, doing both of these ensures that we have a lower rate of missing mutations because the test is simply missing them. Germline testing is also important not only for therapeutic selection, but also to inform family members that they may be at risk for either prostate cancer or other cancers, including things like breast and ovarian cancer, pancreatic cancer, colon cancer, and others. And when it comes to somatic testing, in prostate cancer, at least, we can do testing with ctDNA testing, so a liquid biopsy type approach, or we can test the primary prostate tissue. We can test metastatic biopsies. So there are multiple ways that we can get this testing done, but it is critical that we do the testing so we fully understand the treatments that may be available. Also importantly, those approvals have been in the metastatic castration-resistant prostate cancer setting, but recent advances have also shown us that we may be also considering these combinations in metastatic hormone-sensitive prostate cancer. So the phase 3 Amplitude study reported out relatively recently that the combination of abiraterone and niraparib is superior to abiraterone alone in metastatic hormone-sensitive prostate cancer in terms of prolonging radiographic progression-free survival. And this was recently an improved combination for patients with BRCA1 and BRCA2 alterations. And the TelePro-3 trial, which is looking at talazoparib and enzalutamide in metastatic hormone-sensitive prostate cancer, is actually ongoing, and we should hear relatively soon whether that combination of talazoparib and enzalutamide is associated with superior radiographic progression-free survival as compared to enzalutamide. And this is, I'm sure, something to be considered for those patients included in the trial. Hopefully, we'll see another approval coming here as well, just to give options and access to our patients.
So when we're adding on PARP inhibitors to patients' therapy, there can be a combination of side effects. So you're adding an additional agent on. So it's important to know what to look out for with PARP inhibitors as far as the common AEs, since we'll be seeing these probably used more in practice and then used earlier on in the hormone-sensitive setting. So when patients start on PARP inhibitors, you want to monitor for hematologic side effects, anemia, thrombocytopenia, neutropenia. You want to be checking CBCs and then adjusting dosing as needed. Non-hematologic side effects include nausea, vomiting, diarrhea, or constipation, asthenia, or fatigue. And so we want to ensure that patients have antiemetics on hand for prophylactic use, and make sure that the patients actually are filling those prescriptions, that there's not, insurance roadblocks there as well. And then rare but serious side effects can include AML, MDS, pneumonitis, and thrombotic events. So treating first-line metastatic castration-resistant prostate cancer is complex. Prior therapies impact future choices. One model that some practice uses is the SHARE model that emphasizes patient participation, exploring options, assessing values, reaching decisions, and evaluating outcomes. Dr. Morgans, what are some things that you use in your practice to include in the treatment plan for patients?
Well, I think that things like the SHARE model or conceptual model are a great way to start. I think even just asking patients what's important to you, here are the options that we can provide, here's how they might fit in with what is important in your decision making, and listening to their thoughts, their family's thoughts around logistical concerns and other considerations is really the best place to start. I would also emphasize that this is not just the physician, but it's also, again, the the PA, the NP, the nurse navigator or nurse, as well as the pharmacist, who all join into these conversations to ensure that patients get a full picture of what every treatment is actually going to look like, what follow-up looks like, and what that experience will be, and also to sort of do that re-engagement over time to make sure that the treatment that is the one that is chosen is truly going to be the one that is the best moving forward over time. So lots of people contributing here across the spectrum of the care team.
Yes, agreed. And that is of key importance of working together across these multidisciplinary teams. And to hit on that point, so all members of the care team play a role. So advanced practice providers and pharmacists can play a role in patient engagement. They can act as advocates by explaining therapy options, such as reviewing the differences between ARPIs, PARP inhibitors, and combinations in patient-friendly terms, educating patients on adverse event and management strategies up front to support adherence and then safety. And then also addressing social factors. So if we're in communication with the patient and we learn that they're having transportation issues or other social issues, we can connect those patients to resources and support groups using multiple communication methods, and just collaborating with our other healthcare professionals to ensure the continuity of care. If I talk with the patient, making sure I'm letting the provider know if they are experiencing side effects that I think might need to lead to a dose reduction, but just making sure everyone is looped in on the team. Effective communication, like I said, is critical. We want to make sure that patients are educated early on, and also their family members. So caregivers, include them in those conversations so they know what to look out for and can report it if the patient either isn't willing to or not able to. You want to share the big picture. So what's the ultimate goal of therapy? Upcoming steps. So if we have to move to another therapy, what would that look like? Details about the therapy options. So you want to review access to those therapies, affordability, and then even going into the mechanisms of actions, possible side effects. I know we've hit on that a lot. Emphasizing that these newer therapies work differently than traditional chemotherapy. I think there could be some stigma around ADT and chemotherapy, maybe if talking to family members that have been on treatments in the past. And so just having that discussion that these agents work differently, they're targeted, they do have unique side effects, but those side effects are manageable. And if you're reporting those early on and we're consistently revisiting those side effects, then we can work through those. And then finally, equipping patients with practical tools. So providing printed patient education, whether that be handouts, wallet cards, we mentioned this, but making sure patients have antiemetics or antidiarrheals, probiotics on hand so that they can capture and treat those side effects earlier on and mitigate those so they don't escalate. And then, just encouraging patients to please call, reach out to their APPs, their nurse practitioners, their pharmacists to report side effects, let us know how you're doing. And then, there are opportunities to take breaks in treatment. And there's a lot of data there on taking breaks. So it is okay for us to take a break in therapy, reduce a dose, to help treat those and manage those side effects. There are a lot of exciting advances for our patients with prostate cancer. Thank you, Dr. Morgans, for joining me today.
Thank you so much. It's been my pleasure.
We hope you found this webcast useful and informative for your practice. Thank you for joining.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by educational grants from Astellas and Pfizer Incorporated. To access all materials for this activity, visit peerview.com/DBK860.